Okay, so if with any luck, this will be the least important slide you'll see. This is just who I am, which Pat's already told you about. I want to start you off with an experience that has focused my scientific career. I live in a French-Canadian village just outside of Montreal, and there's a large, wonderful daycare. Walking by the daycare one morning, there's about 33-year-olds out there absolutely having a ball. They're joyful, they're playing, they're interacting with each other, and it's one of those scenes that just brings a smile to your face, right? Not unlike this one. And you sit there and watch, and then, of course, given our profession, you start to think dark thoughts. You realize that 20 to 25% of these kids are going to be experiencing mental health problems in early adulthood, if not earlier. And it's just like this. Here you see a picture of girls. 1/4 of these girls are going to experience clinical depression. Can you pick one out? Neither can we. And that's really the problem. So that's a little bit about what I want to talk to you about and where it is, because at this particular point in time, that aspect of prediction is really, if you will, the focus. Now, in terms of the most common forms of mental health disorder, depression, anxiety, addictions, ADHD, etc., the good news is that these forms of disorder in their most common presentation are largely preventable. The bad news is that your window for prevention is really small. This is data from the STAR-D network looking at the peak age of onset of clinical depression in America. And you can see that it's occurring late childhood, early adolescence. It's about the time of puberty. So your window for prevention is early childhood. That's it. This isn't heart disease. It's not type 2 diabetes. You don't have 30, 40 years. You've got a few years in early life, and as I'll see, early fetal life. And that's your window of prevention. So where are we in terms of being able to predict at this particular point in time? Well, years of epidemiological research have pointed out what are environmental conditions that statistically increase the risk for these common forms of mental disorders. And the list is not complete, but there's the usual suspects: maternal mental health, childhood adversity, abuse, neglect, emotional abuse perhaps in particular, birth outcomes, poor fetal growth, prematurity, low birth weight, poverty, the usual suspects. Now, as clinicians, when we see patients, invariably, when we see more severe cases of mental health problems, the individuals in front of us will have experienced early life adversity in some form or another. And so there's a tendency for us in the clinical world to think that these forms of adversity are actually really quite good predictors of mental health outcomes. What we don't see in our clinical practice, of course, are all those people who experience adversity in the same measure, but have proven resilient, who are functioning very well. And the truth of the matter is that when you actually look at the ability of these environmental factors to predict mental health outcomes, they account for 5 to 10% of the variance at best. They are poor predictors. The message is simple. Circumstance is not destiny, right? So where do we stand with respect to being able to predict outcomes? Well, what I'm going to argue is that our ability to predict mental health outcomes at the level of the individual, which is what is required for effective prevention, is going to require that we integrate not only information related to environmental forms of adversity, but also genetic background. There's nothing unusual about this, right? We know that health outcomes inevitably emerge from this combination. For example, we are all familiar with a thoroughly despicable group of people in our population. People who are able to eat anything and not gain weight. The rest of us hear the word cheeseburger and we've gained a pound, right? This is exactly what we're speaking of, really. And it's portrayed beautifully in some research that was inspirational to me. This is work of René Cadoret, who, despite his charming French name, actually worked at the University of Iowa. I guess Des Moines, who knows. what Cabaret and his colleagues were doing was to analyze outcomes in children who had undergone adoption. And in the particular study that you're seeing presented here, these are kids, and you're looking at the percentage of these kids who have developed antisocial behavior. These children were adopted from biological families in which there was or was not a history of antisocial behavior. So the biological familial influence was either present or absent. And they were adopted into foster families in which there was the presence of antisocial behavior or not, its absence. And what you can see from this graph is that it is only in those children in which there is both the family history, in the biological family of antisocial behavior, and the familial presence of antisocial behavior, in which antisocial behavior emerged in those kids. Neither the genetic, the biological family, nor the current familial environment was sufficient to predict that outcome, right? And that's a common scenario that we see. Fast forward about 20 years, we've now started to look not at proxies for genetics, but at actual genes themselves. You're looking at the classic studies of Absalom Caspi, published about 15 years ago, in which they looked at a very specific genetic variant. Okay? This variant is in a gene that produces a protein known as the serotonin transporter. The serotonin transporter regulates the efficacy of serotonin activity in the brain, and as you probably know, serotonin is very closely related to the risk for depression. So what you're looking at are three variants here. There are those LL, the long variant, which is very functional. They produce large levels of these transporters, and serotonergic transmission is very effective. In contrast, the SS group have a less effective genetic variant. They produce less of this protein, and serotonergic transmission is less effective. Now, what you'll note here is that if you look at those individuals, the SSs, right, at the top graph, is that the risk for depression increased with the evidence for childhood maltreatment, which is what we would expect to occur in the whole population. But it doesn't. If you look down at the bottom, those individuals who carried the long variant, there was no relationship between childhood maltreatment and depression, right? So the outcome was neither predictable on the basis of the gene, nor uniquely on the basis of the environment. It was only by the integration of the two that you could identify that group up at the top that was truly at risk for clinical depression. Now, this, of course, has been captured beautifully, and I'll plug Tom's book, on differential susceptibility, and the characterization of certain children as being dandelions, that is almost immune to the equality of the environment, and others as being orchids, highly sensitive, and thus more likely to be susceptible. So what we've been trying to do, and I'll walk you through this very briefly, is to see whether or not we can move beyond simply measuring a single gene, which of course is not terribly predictive in and of itself, to characterizing the genetic basis for individual differences in susceptibility. And so what we've done is to take advantage of a data set. So this data includes full genome sequencing of about 4,000 individuals. So in each of these individuals, we have the knowledge of millions of these genetic variants, right? These are variants very common. They distinguish you, etc. They're in the population, and we all vary to some extent genetically. What we're trying to do is to understand which of those variants collectively might underlie an individual difference in susceptibility to environmental adversity. So within this data set, we have the genetic information. We also have information related to exposures to forms of childhood adversity that we know predict the risk for mental health outcomes. And in this particular study, the mental health outcome under study is that of an addiction. Okay? So we take our 3,192 subjects, all of whom were exposed to early life adversity, and they're divided into those individuals who were exposed to adversity and developed an addiction. Those we refer to as susceptible. And other individuals who were exposed to the same measure of adversity but did not develop an addiction, we refer to them as resilient. Now we have two groups of people, differing, we think, in susceptibility, and we have millions of genetic variants. What we want to identify statistically, What are those individual variants that distinguish the resilient and susceptible group? And there's thousands of them. And we cluster them together to form a single, what we call a polygenetic score for susceptibility. So that was the measure that we developed. The question then is, does it work? So now what we're doing is we're partnering with the Nurse Family Partnership Program, which many of you will know. It's run by David Olds. It's present in many locations across the United States and now globally in Britain, Canada, Australia, etc. We've been working with David in terms of trying to understand individual differences in the response to the intervention. David's program is a psychosocial program targeting women, pregnant mothers, who were victims of child abuse. And the program's intent is to minimize the chances that these mothers will become abusive themselves towards their own children. And it works, by the way. Now, what we have then is data on the offspring of these mothers by the time, in fact, that they're 27 years of age. We can measure certain mental health outcomes. We have a very precise measure from David's analysis of whether or not these individuals experienced abuse. And we've looked at the genetics. And here's what you find. If you look at those individuals characterized by the black bars, these are individuals who did not experience childhood abuse. What you're looking at as the critical measure here, by the way, is the percentage of individuals within each group that developed an externalizing diagnosis. An externalizing diagnosis would refer to very poor levels of emotional regulation, aggressivity, antisocial or conduct behavior, etc. If you look at those individuals in black, you can see there's generally a stable, low level, regardless of their genetic score for susceptibility, right? So the genetic score for susceptibility, low, moderate, and high, did not, in and of itself, influence the level of externalizing. Now we want to focus on the critical group. Those are the individuals in the red bars. These are individuals who were exposed to abuse. And as you can see, if the individuals were exposed to abuse but were low in their polygenetic score for susceptibility, there's no increased risk for externalizing disorder. We move to the moderate group, higher level of genetic susceptibility. Here, abuse is starting to increase the risk for externalizing. And if we move to the high group, we find, good hands, we find the risk for externalizing disorder is paramount, right? It's the combination of the two. And the reason why that's so critical, we think, is that had you gone in and targeted individuals solely on the basis of their circumstance, you would have included this group on the left in your intervention, who are at no greater risk than children without abuse for externalizing. So again, the argument is that prevention requires prediction, and prediction requires a knowledge of both forms of susceptibility, inherited susceptibility, and circumstance. So susceptibility can emerge from genetic influences, but it can also emerge from early environmental circumstances as well. So I'm going to walk you through an example of that. What you're looking at here, simplification, is what we can loosely refer to as the brain's stress circuitry. The story starts with this area called the amygdala, which is an area specialized to alert you to potential threat. Okay? The amygdala is highly responsive to any form of threat, potential or otherwise, and it then interacts with regions such as the hippocampus and multiple structures in the prefrontal cortex. The net effect of this interaction is to determine the magnitude of your response to this threat, either anywhere from no response to a full-blown stress response, of which you'll hear much later on. So it's the interaction in this circuitry that produces that particular response. Neuroimaging studies have shown that this circuitry lies at the heart of mood disorders, including clinical depression as well as anxiety disorders. Indeed, when you look at the connectivity, the connections between these regions in individuals who suffer from anxiety disorders, what you find is the single best correlate of an anxiety disorder is a stronger neural connection between the amygdala, this threat detector, and an area in the prefrontal cortex known as the insular cortex, which is essentially an area that's responding to, well, how are things going, right? Am I doing okay, etc., right? That connection is stronger in individuals who suffer from anxiety disorders than it is from individuals who do not. Bear that in mind. We're going back to that. I want to tell you about some studies that we've been doing in Singapore for about the past 10 years, where we set up a longitudinal birth cohort of about 1,000 mothers and their children. Moms were recruited during the course of pregnancy. The kids are now, good Lord, 9 years old, and we've been studying them throughout. And one of, I think, our more unique achievements was to be able to do neuroimaging of newborns. Now, that may sound daunting. In fact, for anybody interested in imaging, this is the easiest population you will ever image, okay? What you do, you invite the mother to come into the imaging center at about 5 or 7. Child's a little tired, hungry. You breastfeed. Baby goes to sleep, nice light cotton blanket into the imaging system. We could still be imaging some of those kids, right? And so this situation has provided us with the opportunity to be able to associate the pregnancy condition of the mother to brain structure at the time of birth. And what we see is that this neural circuit, its function and its connections, are largely shaped by levels of mood disorders in the mother. So for example, the symptoms of depression measured on what is referred to as the Edinburgh Postnatal Depression Scale, the higher the symptoms of depression, the greater the influence on these structures. And the structure that is most affected here is the amygdala. And in fact, you'll hear from Sonia Lipion, who has similar data looking at children later on in life. The higher the level of depressive symptoms in the mother, the larger is the amygdala. And that's in newborns. Okay, that's at the time of birth. All of this is being shaped during the course of fetal development. What we also did then was not simply to look at the structure of the amygdala, we looked at its connections in this stress circuitry. And in particular, what you find as an effect of maternal depressive symptoms is a stronger pattern of connection between the amygdala and the insular cortex. That was exactly the profile that distinguished individuals with anxiety disorders. It's there at birth, right? And it's being shaped in part by the mother's level of depressive symptoms. We then follow the kids further on, and we find that the connectivity, the connection between the amygdala and this insular cortex, the one that associates with anxiety disorders, predicts temperament, internalizing forms of temperament, shyness, social withdrawal, anxiousness in the child. It predicts these symptoms at 24 and 48 months of age. The susceptibility is there. Now, I do not want to imply this is destiny, that something has been turned on irrevocably. Years of research in parenting programs, and particularly programs that target mother-child interactions, show that children with difficult temperaments can be completely reversed at this particular point. What's being created here is susceptibility, not destiny, right? So it's just another pathway by which susceptibility is being formed. It's a readout. And if we can capture it, we know that there are interventions, of which many of you have heard, I'm sure, over the last 5 years at this conference, about the efficacy of mother-child interventions. So in essence, what you see, of course, is this pattern that associates with maternal depression. And I'm sure many of you are thinking, is this association between maternal depressive symptoms during pregnancy and the structure of the amygdala and the stress circuitry, is it too modulated by this genetic score of susceptibility? And the answer is yes, it is. In children with a higher polygenetic score for susceptibility, maternal depressive symptoms have a greater effect on the size of the amygdala and its connectivity to regions such as the insular cortex. So in sum, the pathways by which we create susceptibility, this is what we have to capture if we're going to be effective in creating prevention programs. We have to capture more than simply genetic variants or environmental circumstance alone. We need to capture the integration of these two. It is that integration, it is that interaction that shapes the brain, which then moderates the response to adversity subsequently down the lifespan. It's capturing that information and putting it in the hands of individuals working in early life with children, that is our mission at the JPB meeting and the Harvard-centered foundation run by Jack Shonkoff, of which Pat and I are pleased to be members. And thank you very much.